session. I'm Kalevi Kairmo from Helsinki, Finland. My latest research related to alpha therapy comes from MD Anderson Cancer Center Houston. We have two other speakers who have Bad-Pekka background from Germany. First speaker is Aviral Singh, who is now located in Sydney, Australia. So he will speak about targeted alpha radionuclide therapy of neuroendocrine neoplasms. And then finally, Professor Richard Baum, who is now in ICPO and Kuranosticum in Wiesbaden, Germany, will speak about peptide-targeted radiotherapy using cancer-associated fibroblasts as targets in solid tumors. First clinical experience using lutetium, actinium, and deuterium, including tandem approaches against a fibroblast activating protein. So my topic is the prospects of alpha therapy, and I will speak about compounds which are under development, and then some aspects of actinium PSMA, about dose finding and relative biological effectiveness. Then I will speak about briefly about radium and response evaluation and dosimetric aspects and some new ideas related to glioblastoma, multiform and brachytherapy. So Mike Sathekge has been speaking about alpha PSMA therapies. So there are two compounds, actinium PSMA 617, which has been in clinical use, and bismuth targeted PSMA 617 with dramatic responses. Examples here. So what we have to know with actinium, so it's the decay is shown here, and it has 4 alpha particles with different energies and half-lives. The most important are actinium 225 and then bismuth, and it decays to stable thallium. And the clinical trials of actinium PSMA, this is the list. So most of them deal with PSMA 617 and then PSMA IET. And this is how the dose finding has been done. So it's a typical dose escalation trial, starting with 50 kilobecquerels per kilogram, then increased to 100, and then 150, and 200, and then the dose escalation, number of patients, and then the PSA response has been looked at 8 weeks, and then the toxicity has been reported, and actually then the number 100 was found based on the toxicity criteria. You don't see the toxicity, and on the other hand you see better effect than as compared with the 50. So this is the typical dose escalation trial, and now the dosimetry. So for dosimetry, because you cannot really perform imaging with actinium, very small amounts of gamma radius. I don't go now in the details. So they have been using example PET study, and then corresponding, if the patient has been treated with lutetium, so then the corresponding lutetium map, and that's combined with actinium SPECT data, and then you can get the some sort of actinium dose map. And now the dose is based on relative biological effectiveness. and now what we use the RBE is 5 for the ratio of actinium per lutetium, and this is based on this study where cells, actually neuroendocrine tumor cells have been exposed both with lutetium-177 and actinium-225 in cell cultures, and you have calculated the cell killing effect in those cell cultures by staining phosphorylated gamma histone 2A fossa by immunohistochemical to indicate the number of double strand breaks, and then comparing the used amount of energy and radioactive atoms to get the cell killing effect. So this is the average number of the double strand breaks versus the cell viability between the two isotopes. And then if you look at the number, the beta particle energies, alpha particle energies, and then total particle energy per energy decay. So then we get the ratio of the total decay, and then what has been studied here, it's 48-hour decay, so that number is 131, and then you got the cytotoxicity. So the for lutetium it's 10,000, and for alpha it's 14 kilobecquerels per millimeter. So then you get the number 714, and then the ratio here between these two is 5. And with that, I want to say that is taken from that experiment. So it's not tested in prostate cancer cells. So then about the clinical trials. So I recently published with my Canadian collaborators a book chapter about new therapeutic agents. These are busy slides. This just to show how the data has been gathered. So it's actually 6 pages of this, and about 2-3 pages about alpha therapy compounds. So here is a list taken from that. So the most important targets which are in clinical trials are related to hematologic malignancies such as CD33 and 45, typically AML, but then there are other compounds as well, like insulin, like growth factor receptor CD22, and then I will mention fourth hematologic compound very soon. So actinium. So the difference between alpha and beta was already described with that, and then those compounds, lintutzumab, the antibody, and then combined with labeled with actin is called actimab. So those are in clinical trials in various combinatory therapies, and they have already reached phase 3 trials. And then there are some other. There is like neuroendocrine tumors. I will speak about that. And then there is alpha brachytherapy. I will mention that briefly. And here are the lead targeted compounds. So that's for neuroendocrine is this DOTAM-DATE, and then also another compound for hematologic cancers is CD37 monoclonal antibody. Completely new field is targeted alpha particle therapy against glioblastomas. There is this interleukin 13 receptor alpha therapy. This is very interesting compound because it's expressed in more than 75% of glioblastomas, and also the receptor behaves in a different way. It's activated in tumor tissue in different way as in normal tissue. So this is a theoretical very nice compound, and it's also shown by animal experiments and staining that this might have potential benefit. And this is also from the book chapter data. However, the problem here again is that interleukin 13 receptor alpha in gliometry, there are so many other indications and efforts to introduce it in clinical practice. So alpha therapy is only a small portion of this development, but we have to keep this in mind, that this is a possibility. Alpha emitter brachytherapy has been in use. There are multiple developments. We heard last year about radium-224 presentation in the conference from Norway, and this has also been in clinical development. Nice pictures in for example in Israel, and this is the animal data in prostate, colon cancer, prostate cancer, and glioblastoma cells as well. So radium has approved. Again, here are some problems. You can similarly, I did some work already almost 10 years ago about gamma imaging with and dosimetry thing. So you can perform gamma imaging, but the problem is that the images are blurred and they are time consuming. And we analyzed very detailed to try to understand the behavior in patients and also how the response came from, and also to take into account all the concomitant therapies. And we found in 2 patients with 2 lesions the relative absorbed dose, and there were actually 4-fold difference, and this was not depending on the outcome in patients. So the first patient responded, the second one didn't. So we know the alpha radium is in clinical trials, and it is approved. So the indication is castration-resistant prostate cancer, and there are some developments to get new indications, such as breast cancer in certain populations, and then there's also those findings related to other compounds that simultaneous therapy with abiraterone is not suitable with radium. I've been working with osteosarcoma phase 1. We did the phase 1 trial published 2 years ago in clinical cancer research, and the radium recommended dose is also 100 kilobecquerel per kilograms, and it's also targets calcified bony lesions, including brain lesions, lung lesions, and it's not myoablative therapy. And also here are the comments from Journal of Nuclear Medicine related to this work. So we developed new response criteria, similarly with radium, that you have to measure the bone, and we have been using sodium fluoride PET, and sodium fluoride PET you can also use for assessing soft tissue lesions in metastatic osteosarcoma. And these are the NAFSIS criteria, so it's in bone forming disease, which were published about 2 years ago. And response determination is possible regardless of the organ, but it's of course limited to sodium fluoride disease. So we went to study this in a detailed manner. This paper is coming out to use radiomix. So these are 4 metastatic lesions. These are the numbers of sodium fluoride concentration, because you cannot measure radium in vivo. So this is PET data. So this is the intensity, the closer to center, and then these are the periphery. So what happens in these patients, and these are approximately 100,000 data points, each of these histograms. And the data looks like this. So these are lung lesions and soft tissue lesions in the extremities, and you see that basically in the follow-up it seems that the entropy will actually increase. It might be just the opposite what would have been expected. And this is the whole data in those patients. So we had the biomarker data, then we had the resist change, then we had the sodium fluoride data, then we had the FDG data in one patient, then we had the number of radium atoms, and then the intensity profiles, but what happened with those, and then the renew entropy. And actually already in those patients, so basically these patients were those where we had this kind of mixed response and also low activities, and we want to understand that how this therapy should be developed, and that which type of patients would benefit from this alpha therapy. Problem is that the alpha therapy is very and dosimetry especially is very cumbersome. And here are the pictures. So this is the before picture. This is the lung lesion, example of lung lesion. So it's rather dense, then it becomes bigger and then weaker. So resist, of course, increase, but then molecular response may be decrease. And here in soft tissue lesion is hard to get exactly on the same, because it's totally different. So the intensity decreases, but then it becomes bigger. So resist increases. So nobody actually knows what's going to happen. So we have to develop criteria and for these kind of conditions. So in summary, what I said. So radium is approved and improves overall survival. You cannot predict outcome from the early imaging and response evaluation by sodium fluoride PET imaging, and we know this, that there are these limitations with our term. Dosimetry is extremely cumbersome. Breast cancer select indications, and then there are some evidence. Osteosarcoma, no, maybe selecting indications as well. So actinium PSMA compounds are very effective, as well as neuroendocrine tumors. You will hear more about that. And dosimetry is more cumbersome. So other than compounds are under development, especially in hematologic malignancies, and combinatory treatments are going on, are work in progress, but there is not that much what I can tell you right now. So I thank you very much for your attention, and Thank you for listening.
Thank you for the opportunity to present at this esteemed conference. I will present on targeted alpha radionuclide therapy of neuroendocrine neoplasms. I have no disclosures. So following the remarkable results of the NETTER-1 study with respect to efficacy and safety profile, beta radiation PRRT has become the preferred mode of radionuclide therapy for neuroendocrine neoplasms. PRRT with beta emitters has a good clinical effect. However, a relatively large penetration range of the beta radiation may potentially impact on adverse effects. Additionally, cancerous tissue tends to become resistant to beta radiation therapy over time. Despite the currently available treatment options, many patients suffer from progressive disease, sometimes which may lead to lethal outcomes. There are limited treatment options, particularly after the failure of beta PRRT. Therefore, there is an urgent need for next-line, well-tolerated therapies for metastatic neuroendocrine neoplasms. Literature has shown that targeted alpha radionuclide therapy can be applied to enhance the anti-tumor effect in order to overcome beta radiation resistance in somatostatin receptor positive neuroendocrine tumors after PRRT with beta particles. There are some distinct advantages of alpha radiation mediated targeted radionuclide therapy, which includes a higher linear energy transfer, which reciprocates to higher probability of double DNA strand break. The alpha radiation also has a shorter range of tissue penetration, which may result into the less possibility of damage to adjacent healthy tissue. And so far, there have been no major adverse effects expected with reasonable doses. And in some cases, application without special radiation protection equipment is possible, given the short range of the alpha radiation. On the other hand, there are certain limitations to the application of alpha radionuclide therapy, as mentioned here, and will be stated later in this talk. The concepts of radiobiological effects of alpha-mediated radionuclide therapy and radionuclide therapy in general are diverse and can be broadly divided into targeted and non-targeted effects. The targeted effects generally include a plethora of intracellular mechanisms, including DNA strand breaks, double DNA strand break in the case of alpha radiation, release of several factors causing cellular hypoxia, and subsequent demolition of cellular structures. Non-targeted effects include bystander effect, which are produced by irradiated cells, which can communicate with nearby cells either through gap junctions or the release of intrinsic factors, which cause cell death. Non-targeted effects also include systemic or abscopal effects, which involve generalized immune system response activation mediated via CD4 and CD8 T lymphocytes through the release of various factors such as dendritic cells. Apart from these multiple complex factors, there is also genomic instability, which is caused by irreparable radiation-induced DNA damage. Despite the evidence of advantages of alpha radiation, the clinical evidence for targeted alpha therapy of neuroendocrine tumors is limited. Literature search reveals one retrospective case series, one retrospective study with interim analysis, a registered and active prospective single-center trial, and sporadic case reports of targeted alpha radionuclide therapy of neuroendocrine neoplasms. This retrospective heterogeneous single-center first-in-human report of clinical case series of alpha radionuclide therapy, predominantly via intra-arterial administration, in only 8 NET patients refractory to standard of care, and beta PRRT demonstrated partial remission in 25%, stable disease in 38%, and complete remission in 1 patient, whereas 2 patients were not analyzed. With regards to adverse effects, reportable hematotoxicity was observed in 4 patients and mild nephrotoxicity in 1 patient. 1 patient, however, went on to develop Graves' disease, which was attributed to alpha radionuclide therapy given its occurrence post-therapy. So all in all, the initial case series demonstrated effective clinical use of alpha radionuclide therapy in beta refractory neuroendocrine tumors. In this case series, there was also a patient with prostate cancer with neuroendocrine differentiation. This study by Balal et al. Is a well-designed prospective case series with a well-defined patient cohort, a systemic treatment algorithm, and a standardized measurement of outcome with regard to the timing of the radiological image acquisition and assessment of biochemical response with chromogranin A. The interim results of 32 patients, which were stable or progressive following beta PRRT, reported in this study of targeted alpha radionuclide therapy with actinium dotatate, revealed interesting results, showing 63% objective response and 100% clinical benefit. There was also a clinically significant reduction in the tumor marker chromogranin A. In this study, no significant biochemical complications such as grade 3 or 4 hematotoxicity, nephrotoxicity, or hepatotoxicity were observed. Overall, targeted alpha therapy using actinium-225 dotatate following failure with beta PRRT was well tolerated in this cohort of patients without any severely debilitating adverse events. This slide shows attempts of establishing alpha radionuclide therapy using lead-212. The preclinical study of lead-212 labeled dotamtate paved its way to clinical application. This phase 1 non-randomized open-label dose escalation single-center study is designed to determine the safety, biodistribution, and preliminary effectiveness of lead-212 dotamtate with the trade name of Alphamedix in adults with somatostatin receptor positive neuroendocrine tumors. This is an ongoing trial which includes PRRT naive patients. So one must note that the patients here have not received beta PRRT. The image here at left bottom from interim results shows encouraging response to therapy in a patient with stage 4 pulmonary neuroendocrine tumor following 4 cycles of lead dotamtate therapy. The clinical trial has completed dose escalation phase and is entering expansion cohort phase and is in preparation for registration trial. The final results are still pending. However, this drug has received orphan drug designation by the FDA. Here I would like to present a patient from our patient cohort treated on an individual case compassionate basis with alpha radionuclide therapy. This is a case of a 46-year-old female with non-functioning thymic net with pleural and pericardial metastasis. It must be noted that thymic neuroendocrine tumors is an extremely rare tumor, accounting for up to 0.02 to 0.18 per 100,000 per year in Europe and USA, respectively. And treatment of recurrent thymic nets remains challenging. So following diagnosis in April 2002, the patient went on to receive palliative tumor resection, followed by adjuvant radiation therapy. From 2003 to 2005, the patient received somatostatin analog therapy. And from August 2004 to February 2006, the patient was treated with interferon alpha. In early 2006, the patient was restaged using gallium-68 DOTATOC PET-CT, which showed multiple foci of strongly somatostatin receptor positive pleuropericardial metastasis, as seen here on the MIP images as well as axial images. Following recommendation of Neuroendocrine Tumor Board, the first phase of beta-PRRT resulted in molecular complete remission of the disease, which was observed in February 2009. Further recurrences were again noted and treated with multiple, in total 8 courses of personalized beta-PRRT using yttrium-90 as well as lutetium-177 until September 2019, resulting in satisfactory progression-free survival intervals variable up to 30 months. In September 2019, massive disease progression was observed with significant clinical deterioration. The KPS or the performance score reduced. There was significant weight loss. The patient suffered from dyspnea, anorexia, and fatigue. At this stage, the Neuroendocrine Tumor Board decided to commence alpha radionuclide therapy following failure of disease control with beta-PRRT. A single administration of alpha PRRT with 19 megabecquerels of actinium DOTATOC were well tolerated by the patients, with remarkable molecular and morphological response and clinical stability, with improvement in functional status, weight stabilization, and improvement in breathing capability. Furthermore, following alpha PRRT with actinium DOTATOC, there was no evidence of immediate or late clinically relevant adverse events or hematotoxicity or nephrotoxicity in this patient. To summarize, applying the principle of personalized precision medicine and given limited current clinical evidence, targeted alpha radionuclide therapy can be considered feasible, effective, and safe in patients with neuroendocrine tumors refractory to beta-PRRT, resulting in prolongation of progression-free survival while maintaining a reasonable quality of life without severe debilitating side effects. The advantages of targeted alpha radionuclide therapy, as already discussed, include a higher probability of double DNA stand break along with bystander and systemic effects. Given the higher linear energy transfer over a shorter range in tissue, which would then have a less possibility of damage to adjacent healthy tissue, which would then relate to a possibility of less severe adverse effects in such cases. However, limitations of targeted alpha radionuclide therapy still persist. There is relatively lower incidence of disease, and therefore lower number of patients are evaluable in a proper clinical setting. And mostly these treatments take place in really very specialized centers. There is restricted availability of the respective radionuclides. There's limited source, difficulties of production, handling, and distribution of the radiopharmaceutical. There is also a demand versus supply imbalance, which one sees, say, for example, in the cases of prostate cancer, which also, say, uses actinium-225 PSMA, which is also now a concurrent or a competitor for patients receiving radionuclide therapy for neuroendocrine tumors. So there has to be a share of the quota of the available actinium, which is available in the market and able to be produced reasonably. Therefore, the above situation leads to limited clinical experience and thus a lack of clinical trials. So essentially, despite the promising initial data or limited current data available on targeted alpha radionuclide therapy of neuroendocrine tumors, there should be further increase of the awareness and education of such therapy, and further well-designed prospective clinical studies with larger patient numbers remain warranted. Thank you very much for your attention.
Thank you, Professor Kalevi, and the organizers of the 16th International Conference on Radiopharmaceutical Therapy. My name is Richard Baum. A warm welcome to everyone around the world listening to this lecture. My topic today is peptide-targeted radiotherapy, actually using as target fibroblast activation protein. So a little bit on the background on tumor microenvironment and the so-called cancer-associated fibroblasts, or CAFs, which are part of the tumor microenvironment and present in a large number in the tumor stroma of malignancies, such as breast, colon, and pancreatic, and many other cancers. And you see here is a stromal component with the epithelial cell, the normal fibroblasts, and then the cancer cell. And when the cancer gets more aggressive and invasive, there is an increase of the fibroblasts and the vessels around the tumor, and many other factors like immune cells, and also secreted substances from the tumor cells and from the CAFs here. And actually, the CAFs are part of this like an infrastructure which supplies the tumors, especially with growing new vessels and supplements. The characteristic of the FAP is that it is a type 2 transmembrane cell surface serine proteinase, which belongs to the DPP family. And there is also soluble or circulating FAP, which results from post-translational cleavage. Actually, FAP is a peptidase for various substrates, for example, denaturated collagen, neuropeptide Y, substance P, and so on. And it is involved in a complex interaction within different cell signaling pathways, which are mentioned here. The structure is actually it's a 760 amino acid glycosylated homodimer, and the crystal structure is available. Some of this is shown here on the right, according to the publication of Ley. And FAP expression is strongly induced in scar formation processes, but little is known about the physiologic regulators of FAP expression. It is often correlated with disease progression and severity, and linked to various pathologies like liver and pulmonary fibrosis, rheumatoid arthritis, atherosclerosis, autoimmune disease, keloid formation, and it plays also a great role in cancer. Because FAP expression in normal tissue is usually low or undetectable, but it is overexpressed in many cancer types. And we see also increased expression in stroma, and therefore FAP is seen as a universal marker for CAF. And FAP expression in the tumor-associated stroma, and sometimes also on the surface of certain cancer types, like for example, gastric cancer cell or sarcoma, is present. And FAP overexpression is associated with various cancer types. I mentioned already some, but there are more than 30 cancers meanwhile known. Among them, the most prevalent, like colorectal cancer, breast cancer, lung cancer, pancreatic adenocarcinoma, glioblastoma, ovarian cancer, myeloma, melanoma, and many others. And as a rule of thumb, one can say that FAP expression is often associated with worse clinical outcome and tumor progression. However, there is also a controversial finding in certain cancer types and a distinct mode of action on tumor proliferation, migration, and invasion. And some assume that FAP is involved in immunosuppression, but also tumor suppressive effects of FAP were described. And FAP 2286 and also 3940 are conjugates of FAP binding peptides coupled to a radionuclide chelator, you know it all, DOTA for imaging and potential therapeutic applications. So the first report on the use for therapy was actually in October 2019, and our first results were just recently published in the Journal of Nuclear Medicine. The aim of the study is mentioned here and the rationale. So there was extensive preclinical characterization of the FAP binding peptides, for example, by FACS, enzymatic activity assay and binding assays, and also in vivo using xenograft models for tumor imaging and biokinetics for selection of the best candidate. And many of these were really screened. We report here our initial experience with the radiolabeled peptide FAP2286 for molecular imaging and peptide targeted therapy of patients with advanced metastatic cancers after exhaustion of all other treatment options. And that was, as I mentioned, in 2019 at my previous institution, Zentralklinik Bad Berka. And actually, since beginning of 2021, we were using a novel FAP peptide, which is called 3940 at the Curanosticum here in Wiesbaden in 10 patients. So the methods here are shown. In 2019, we studied actually 11 patients with advanced adenocarcinoma, pancreas, breast, ovarian, and colorectal. After confirmation of significant tumor uptake, measuring SUV on gallium FAP2286 PET, or in one patient also using FAPI as a small inhibitor, which the study was done at the German Cancer Research Center. Biodistribution was analyzed by post-therapy planar and SPECT-CT images with dosimetry estimations. We also evaluated the clinical parameters, laboratory findings, and tumor markers. And in Bad Berka, we administered FAP2286 over 5 to 10 minutes without renal protection. And the activity ranged from 2.5 to 9.9 gigabecquerel lutetium FAP. And it was chosen individually and based on the patient's clinical condition, hematologic and renal function, as well as uptake in the tumor lesions. And additional cycles were administered when the patients consented and when their condition allowed for it for further treatment. And one patient received a single cycle, and 9 patients received 2 cycles, and 1 patient 3 cycles of PTRT. Response to treatment was determined by molecular and morphological imaging, as well as sequential determination of tumor-associated antigens. This is one example of a 60-year-old patient with progressive pancreatic adenocarcinoma, large liver metastases, as you can show here on the scene here on the PET. Also, lymph node metastases were present and bone metastases. And he had received multiple chemotherapy cycles. And here are shown SPECT-CT images using lutetium FAP2286 48 hours after injection, which confirms the long retention of the peptide in the tumor. This is another patient with disseminated bone metastasis from breast carcinoma. And you see here the gallium scan with diffuse involvement of bone marrow and bone. And these are serial whole body images, 15 minutes, 3 hours, 20 hours, 44, 68 hours, and 7 days, and up to 10 days after injection. And you see clearly that there is very early uptake, for example, in this lesion in the left shoulder, which remains present until 10 days after injection. And she has received all treatment options, and we treated her actually with lutetium FAP2286. And these are the follow-up scans shown here and published in the journal, showing the FAP2286 PET-CT after 8 weeks now, and comparison between the previous scans and the follow-up scans. Unfortunately, there was progressive disease with now liver metastases also imaged on the PET-CT. These are dose estimations for whole body, kidneys, and red marrow. And to make a long story short, there is only very little radiation going to normal tissue, which also is reflected in the CTC CAE. So there were no adverse effects on bone marrow function or on blood counts. And you see here's the levels before and after treatment, which do not show any significant hematological toxicity. These are the SUV max we measured in representative target lesions in the liver and lymph nodes and bone metastases. And you see that some patients had SUV up to 30, which is actually much higher than those SUVs measured for FAPI for the small ligand. And this resulted in a mean absorbed dose in gray per gigabecquerel. You see here up to 10.6 per gigabecquerel. And in bone metastasis here up to 100. These is a half-life up to 120 hours in tumor, which then results in a significant tumor dose. These are the tumor markers in some of the patients, which show that there is no dramatic reduction of tumor markers concerning CA19-9, CA15-3, or CA125. And this is the outcome of these 11 patients. And you see, unfortunately, all patients had progressive disease, and there was actually most of the patients were dying after some time. So we have seen specific uptake and long tumor retention on delayed imaging in all patients. The mean absorbed doses for whole body were very low, and also for red marrow and kidneys, and only mild to moderate adverse effects were seen in the patients with self-limiting headache, for example. There were some clinical reduction of effects like pain, decreasing pain, and also reported by one patient for a longer time. No significant, as I mentioned, renal or hematological adverse effects. And 6 out of the 11 patients, meanwhile 7 out of the 11 patients died over an observation time of now more than 1 year. Now coming to FAP 3940, actually this peptide is quite similar to 2286, but with some possible improvements. And we used it since March 2021 in 10 patients with advanced adenocarcinomas. I will show you later the table after prior confirmation of significant tumor uptake, again using PET-CT, this time using the 3940 peptide. And we also analyzed the biodistribution after therapy using SPECT-CT from skull to mid-thigh and also whole body imaging. And again, we were looking at the clinical parameters, laboratory finding, and tumor markers. The 3940 was administered IV over 1 minute, again without any renal protection, and the injected activity was chosen individually and additional cycles administered when the condition of the patient allowed for it. And response to treatment was again done by PET-CT and morphologic imaging, as well as tumor-associated antigens in blood. This is quite a busy table, but it shows you the 10 patient age, gender, primary tumor, so prostate cancer, pancreatic adenocarcinoma, neuroendocrine neoplasia of the thymus, which had not a significant expression of somatostatin receptors. Then sarcoid-like ovary adenocarcinoma, atypical lung carcinoid, esophageal adenocarcinoma, and just recently a clear cell sarcoma of the small intestine, a very rare tumor. You see that all patients were heavily affected by metastases, mostly in the liver and bone and so on. In some patients, we could identify genetic changes. Some patients had previous surgery. Most of them had chemotherapy or radiation therapy, and some also immunotherapy. Up to now, most patients received 1 cycle. 1 patient received 3 cycles. I will demonstrate this patient. And for the first time, we were using also not only lutetium, but also yttrium-90 and actinium-225, and also combinations of lutetium and actinium and yttrium and actinium, so-called tandem therapy. Many of the patients showed progressive disease, but we also find a patient with stable disease and 1 patient with a response to the treatment. So as you can see here, 4 patients died and 6 patients are still alive. So I will present this case of a squamous cell carcinoma of the oropharynx with multiple lymph node, pulmonary, and bone metastases. Initial diagnosis was in February 2019, and he was treated with external beam radiation therapy and concomitant cisplatin chemotherapy, recurrence, and again chemotherapy, radiation therapy, immunotherapy, and then all options were exhausted, and the patient came to us end of March for treatment, and we treated him first with 5 gigabecquerel of FAP 3940, and then again in May with 5 gigabecquerel lutetium in combination with actinium. So this was a first tandem therapy using an activity of 15 megabecquerel for injection. This actually is the gallium FAP 3940 PET-CT, and you can see the tumor recurrence in the oropharynx area, also bone metastases, which are also shown here on the sagittal and transversal and coronal images. We also had seen some uptake on the PET in the area of his tubus, and we have detected small metastases in the lung down to a size here of 7 millimeters or even 5 millimeters, which you can recognize here, and quite rare localization of the disease, metastasis in the thyroid, for example, and again, some reactive uptake in the tube, in the gastro tube the patient had here, but also in very small lymph node metastasis in the mediastinum. This is a lutetium SPECT after 3 hours, and you see already after 3 hours quite good uptake in most of the lesions, also of course seen on the gallium PET, and we see very little uptake, if any, in the kidneys 3 hours after injection, and no significant uptake in the liver. Unfortunately, the patient, no, this is first of all an image 42 hours after 5 gigabecquerel, and you see infiltration with metastatic infiltration in the lung and persistent uptake here in the bone metastasis and in the primary tumor. Unfortunately, the patient had progressive disease. You can see here now the gallium PET in middle of May, which shows a significant increase of the tumor load in the oropharyngeal area, but now also diffuse lung metastasis also recognized here on the lutetium SPECT. So the patient unfortunately died due to bleeding in the mouse and was not really profiting from the therapy. This is another patient, again, with ductal adenocarcinoma of the pancreas, with liver metastasis, peritoneal implants, pleural and pulmonary lesions, as well as soft tissue involvement. You can see here the previous treatment, which was standard of care. He had also a lot of accompanying diseases, and we treated him in May with tandem PTRT using lutetium and actinium, and again in July with the same schedule, and then in November with yttrium-90. So you see there was a long time between the second and the third treatment because the patient was unable to travel at this time. And here are some images after the lutetium actinium tandem therapy. This is a 2-hour image showing the primary tumor and the liver metastasis here. On the right upper corner, you see actually a scan after 48 hours, and here after 144 hours. So long persisting, very nice uptake we can see here in the primary tumor and in the liver metastases. This is another scan just showing you again no renal uptake with the peptide, and also no uptake in normal organs or in the normal bowel, for example, but high uptake in the primary tumor. This is a follow-up of the patient. This was before the first treatment. This was before the second treatment in July. And then he had this long break. And you see how aggressive the tumor really is. So there is a significant progression in the liver, which is now heavily involved with tumors, and also many metastases in the bone and in the abdominal area. This is another patient, with poorly differentiated epithelioid pancreatic adenocarcinoma and disseminated liver metastasis and stomach infiltration. She came actually from Stanford University after she received all kinds of therapy, including robotic distal pancreatectomy, chemotherapy with FOLFIRINOX, gemcitabine, and paclitaxel, and also immunotherapy using neoepitope, vaccine, and so on and so on. And she also had MRI-guided external beam radiation therapy in the paragastric area. And we started treatment in September 2021 with 5 gigabecquerel yttrium-90 and quite a high activity of actinium-225 for the first cycle, and then followed up with 2 cycles of yttrium-90 up to 7.6 gigabecquerel, which is more than 200 millicurie of yttrium-90, please, without kidney protection. This is a patient. She allowed me to show her image, and you see when I injected the activity via the port she had here on 1st of September. And this is an image from July before the first treatment with heavy involvement of the liver. And you can also see very nicely here the high uptake in the primary tumor, as well as on the transversal slides, the liver metastases here. And then my hero, Paul Ehrlich, said, frappe fort, frappe vite, hit hard and early. And I think this is what we have to do in this very aggressive type of tumors. And you see here now images with 200 millicurie yttrium-90 FAP 3940, 30 minutes after injection with very good uptake. You see here the uptake in the activity in the standard is 8.4 megabecquerel, and it's even higher here in the metastasis in the liver. This is after 4 hours, and after 44 hours still quite good uptake in the metastases. This is then under the second treatment. She had received, in addition, transarterial chemoembolization of the liver metastases, and you see some of the lesions are necrotic, but there are still vital metastases with a high uptake of the FAP peptide, as shown on yttrium-90 SPECT-CT. You see that the images are quite good with yttrium-90, which was surprising for me how good images we get with yttrium-90 here. And then you see the follow-up in November, just recently. She was here for the third therapy, and you see the significant reduction in tumor load in the liver metastases. And you can, I think, also appreciate that on the gallium PET-CT before treatment, and this was then after the second treatment, and this was actually before the third treatment now. And the last patient I will show is esophageal cancer patient with heavy, extensive abdominal, mediastinal, and cervical lymph node metastases. And he received 7 gigabecquerel of yttrium-90 FAP 3940. And this is a FDG PET, which was done in Los Angeles. And you can see here the primary tumor and the lymph node metastases in the cervical region, but also in the abdomen. And this is just 6 weeks later with FAP. You see here now a new metastasis coming up, a more extension of the primary tumor, and a much heavier involvement of abdominal lymph nodes, and also a lymph node actually in the iliacal area. And after the treatment, we had seen a very significant decrease of uptake in the cuffs here, and an improvement, very significant clinical improvement. He had a weight gain of 4 kilograms, and before he could not eat any food, just he was drinking calories, and then he could eat schnitzel again, how he said, and that without any significant adverse effects. So in summary, concerning FAP 3940, we have specific uptake and long tumor retention seen on lutetium and yttrium-90 FAP 3940 imaging. Extremely low accumulation was seen in normal organs, especially in the kidneys, and only mild or no uptake was noted in benign conditions, which we had seen on PET-CT, like, for example, in the uterus or in abdominal scars or in the myocardium. And no significant post-therapeutic adverse effects were reported by the patients, except for fatigue in some patients. and no grade 3 hematological side effects and no renal side effects. Follow-up using molecular imaging and tumor markers revealed cytotoxic effects in patients treated with tandem yttrium-90, actinium-225, PTRT, and I think alpha radiation and high LET is needed to kill CAFs because CAFs are not so fast proliferating cells. They are more resting cells, whereas strong beta emitters might be necessary to kill tumor cells by crossfire effects. And 4 out of the 10 patients died over an observation period now of 8 months as a result of disease progression. So in conclusion, these initial results provide preliminary evidence for the feasibility of radiomolecular precision theranostics using the novel radiolabeled peptide FAP2286 and also the lutetium, yttrium, and actinium labeled FAP3940, as well as tandem therapy using combination of lutetium and actinium or yttrium and actinium in a number of advanced therapy refractory adenocarcinomas. Specific uptake and long tumor retention of the radiopeptides ensure usability of therapeutically effective, longer-lived radionuclides for therapy like actinium-225. FAP peptide-targeted radionuclide therapy has a very low toxicity profile. So with now nearly 2 years follow-up after the first use of lutetium FAP2286, we had not seen any significant renal or hematological toxicity, and FAP2286 is currently being investigated in a phase 1/2 multicenter open-labeled non-randomized clinical study, which is called Lumiere, for safety and tolerability, and also for the determination of pharmacokinetics, dosimetry, and preliminary therapeutic activity in patients with advanced solid tumors. And I think our task for the future will be to find the optimal injected activity for treatment, especially concerning yttrium-90 and actinium, and the administration schedules and combinations with other cancer treatments, for example, checkpoint inhibitors or immunotherapy. So I would like to thank many people here, especially my team at Cohernostics, Lukas Greifenstein, who is a radiochemist who did all the labeling, Aditi Mishra and Carsten Kramer and Alexander Eismann, my clinical colleagues, and from 3BP, especially Christiane Schering for giving support to this study. And before I finish, I would like to invite you all to the 6th Theranostics World Congress, which was actually planned this year in Santiago, Chile. However, due to Corona, we had to cancel this meeting and decided to have the next Theranostics World Congress end of June 2022 here in Wiesbaden, Germany. And I hope you follow all. Thank you very much for your attention.
So can you hear me? Great. So thank you very much for this wonderful session. It was very informative. And unfortunately, we do not have Professor Baum or Professor Kalevi with us at the minute. However, I understand we got a couple of questions. So one was regarding the salivary gland protection. I think about that we have discussed reasonably extensively in the lecture from Professor Mike Sathig from yesterday in the prostate cancer session. And for neuroendocrine tumors, we actually do not need any salivary gland protection simply because of the mechanism. Dotatate, the DOTA compounds or somatostatin receptor compounds do not accumulate in the salivary gland. So basically, you do not need salivary gland protection there. I think there was another question which was asked by another question asked by Dr. Jeremy Ong is regarding the various radionuclide daughters that are still bound. So regarding the decay resulting in daughter isotopes that also emit alpha particles, is there any way to confirm that these daughters are still bound to the ligand, especially due to the long 10-day half-life? Is there any concern that daughter isotopes are freed from the ligand and circulating without targeting? So that indeed is a very good question. And I would say, Jeremy, there are no definitive answers to that question. However, theoretically, this is possible, which could be the cause of the radiobiological effects as mentioned in my lecture in one of the earlier slides. If the daughter, radioactive daughter nuclei, if they are present within the cell structure, which have been engulfed by or phagocytosed by the cells, then they will continue to cause the therapeutic effect. And that is why we see lots of bystander effects, which we are still not certain about, but that is a great possibility. However, if you say that the cell is destroyed and these daughter radionuclides are released into the circulation,
We seem to have lost Dr. Singh. So with that, we will actually close this session and get ready for the, I see Dr. Singh again. Try it again.
How come? So what did you hear, Josh?
We got right to the little bit left of the, actually, I'm not sure where we got to.
Okay, so I'll just try to complete that. So essentially, with regards to the daughter radionuclides, if they are within the cells, they will, if they're phagocytosed within the cells, cancer cells, they will continue to have therapeutic effect. And in case the tumor breaks, the tumor cells break down, and these, as per your question, if these are released into the circulation, some of them will, of course, pass through the normal with the circulation with normal physiological organs, where they might cause some damage to the tissue. However, you must remember, if they are only alpha emitting, then they have a very, very short range. So this is still safer. And at the end of the day, these are going to, if they are in the circulation, they're going to be excreted via normal physiological pathways, whether through feces, urine, or breathing, or otherwise. So, and that's why we do have the bystander effects that we see, and we've discussed in the lecture earlier. Of course, that's a very detailed chapter on its own altogether. I hope that answers your question.
And I think the last question is AC225 DOTA therapy in larger lesions useful?
Actinium in larger lesions useful. Yes, it is. We have actually seen in patients. I mean, the case that I presented, if you see the lung lesions, it was complete, or the pleuropericardial lesions were extensive, and that patient had excellent therapeutic effect, because it's about the DOTATATE actually binding, or DOTATOC actually binding to these sites and causing the effect. So and also, say for example, in prostate cancer, actinium is one of the indications for use of actinium is extensive disease, and we do give actinium. Moreover, in DOTATATE, we give much larger doses, so not just 5 or 8 megabecquerels at max, which has been proposed. We've used up to 20 and plus megabecquerels of actinium DOTATOC or DOTATATE in our patients with excellent results, and that's what you saw in one of the patients that that I presented. So here we have a larger room to play with. The only trouble is that actinium is really, really difficult to get and getting costly by the day now.
Okay, and with that, since Dr. Baum isn't here to answer the FAP question, I think it's time to close the session and get ready for our oral abstract session and closing session. So thank you very much for joining us.
Brilliant. Thank you. Thank you, Josh.